Okay, if you could all take your seats, please. We're running to a tight timetable and we're already running 5 minutes late, and that's pretty standard for medical researchers. I mean, coffee is always more important than the science, but we've heard from pathologists, being myself and a physician, and in this next session we're going to hear successively from a surgeon, somebody in general practice, and somebody from the dark side, and that's Andrew Cuthbertson down here. Ingrid said that I should remind you, and I suppose it's a fair thing to remind you, that in your professional career, whether you wish to be a medical researcher or not, you will be, because the reality is that it's going to be increasingly important that at the very least we're all good at health services research and demonstrating that we are delivering the best possible care that we can through doing the research that will show that that's what we're doing. That branch of research is actually one of the less well recognised ones, but it's actually one of the most important if we're trying to persuade government that we're doing the best we can for our patients. If we don't actually look to see if we're doing the best that we can, and if we're not, find out why we're not, then we're not doing a good service to our patients. And I'll just remind you that although Semmelweis told us all that we should be washing our hands between patients nearly 200 years ago, we still have this problem that 40% of healthcare professionals do not wash their hands between patients, and we still have the reality that nosocomial infections are the commonest infection that bring people into hospital. So, or at least they get it while they're there. With that note, I'll get this session underway, and we're going to hear first of all from Professor Kate Drummond as a surgeon who's going to tell us all about how to make surgery work as a research career.
Good morning. It's a real honour to be asked to speak at this forum. Thank you for inviting me, Ed and Ingrid. I must admit, I've actually been a little bit nervous about giving this talk where there's some actual smart people talking before me. And I've been very heartened by the fact that Ingrid and my message is exactly the same. So I'm feeling a little bit better. So if you're a surgeon, why do research? You know, why would you not just spend all day operating? Well, yep, that's what I love to do. Spent all this time learning how to do it. It's a physical skill. A physical skill needs to be practiced, and you only get good at it if you do it lots of times. It's exciting, it's fulfilling, it's also scary and responsibility laden, so you want to do it well. So why indeed would you also want to do research? So I think from that, for me, comes sort of three questions that we need to answer. Why would surgeons not do research? What do surgeons specifically bring to research? And then why would surgeons do research? So this is a fairly simple one to answer. Why would surgeons not do research? And each of the speakers even so far has touched on this. Because research is hard, it's time consuming, and it's sometimes soul destroying. And surgeons don't necessarily deal with this very well. And I'll give you an example of that, and I'm so pleased to hear that your PhD took 20 years. So this is me getting my 11-year MD. I was very happy on that day. There's some of my rats, and I made some lovely blue brain tumours, and I started out thinking I was going to cure cancer. And of course, in the end, I had a thesis and not much else. And it was very difficult. It was a struggle for me, and I came to the end of my laboratory research realising that I am not cut out for laboratory research. The nature of surgical work is very different. The bad thing about research, and there's one of my PhD students in the audience, and this is something I've told him a million times, is that the trouble with research is there's not much that actually has to happen tomorrow or in an hour. It can always sort of go to next week or next month or whatever, whereas surgical work is very different. It's tonight, it's tomorrow, it's on the day that the patient turns up. So we have a very different mindset. And so I learnt very quickly that for me, the sort of laboratory research thing, and I thought, oh yes, I'm going to be, you know, a laboratory researcher, a basic scientist, a surgeon, a bit of everything, actually was not for me. But then that leads to sort of the next question is, well, what do surgeons bring to research? We know how to ask good questions. I mean, this is just off Google, but it did amuse me. I'm not quite sure what this poor, probably enormous research team was trying to achieve by working out the rectal pressure in a model penguin that shot a poo 40 centimetres. And I might be missing the point, because remember, I'm not a very smart researcher, so maybe I'm missing something here. But we know how to ask the right questions and good questions, because we sit and we look at the patients and we think things like this. So we noted a problem. We've got 2 brain tumours there. The one at the top, what's your top right, is a low-grade tumour. And the one in the middle is a high-grade tumour. And we treat those completely differently. We do completely different things for those patients. But sometimes what it looks like on the scan isn't what the pathology comes back as. So sometimes you've got a tumour that on imaging looks like a high-grade brain cancer, but the pathology comes back as a low-grade brain cancer. And we said, well, what does that mean? What should we do? Because if your pathology says low grade, you want to get treated like a low grade. It excludes you from a lot of aggressive treatments and a lot of clinical trials. And so we had a look at that, and that was a really good question, because what it showed was the good survival there. The blue line was if you had pathology and a scan that showed you had a low-grade tumour, then you'd live like a patient with a low-grade tumour. But if either your pathology or your scan, even if they were discordant, showed that you had a high-grade tumour, then you would die more quickly like a patient with a high-grade tumour. And that allowed us to change our treatment paradigm and much more offer treatments for patients with high-grade tumours to those with scans that look like high-grade tumours, even if their histopathology was discordant. So that was the sort of little questions that surgeons can ask and answer. And we have the patients, and particularly for surgeons, we have the tissue. And that is vitally important. And that's been a real sort of platform of my research career, in that I can collect data on all of my patients and I can collect tissue on all of my patients. And that has led to a lot of the work that I've done. So on the little screenshot that you see there is our brain tumour database, which has been through multiple iterations, and every patient that goes through my hospital with any sort of brain tumour gets registered in there, and it's their follow-up data when we can get it put in there. And on the other side are some glioma stem cell clusters that we've grown by taking people's brain tumours out and sending them to the smart people in the laboratory. It should be either against the Geneva Convention or a crime against humanity to take a piece of tissue out of a patient and not have it banked for someone's research somewhere, and have the knowledge that that tissue is banked publicly available worldwide. And that's something that surgeons, in a very real way, and by being involved, by giving, not just giving you your tumour samples, but also giving them as clinically annotated tumour samples, how long the patient lived, what happened to them, were they different from other patients? That's something that surgeons really can contribute to the research community. So we've been doing that for a while. Just show you some little examples of what's come from that. We've now got, well, we called them Parkville 16. It makes it sound like a bit of a gang, but a panel of stem cell lines that are being used by researchers across Australia looking at brain tumour research, and using some very clever technology, wherever Wayne is. Here's your slide up here, Wayne. He's there in the audience somewhere. Using some very clever technology by making these stem cell lines glow, we can watch their growth in mice and then use them to test different treatments for brain tumour patients. So just collecting that tissue has made a huge difference, and, you know, completely self-servingly has led to a lot of papers. So just looking at our patients' clinical phenotype and particular characteristics of the tissue that we collect, we've been able to do quite a bit of research looking at the etiology of tumour-associated epilepsy, about looking at how metastatic tumours may differ or be the same as the primary tumour when they go to the brain, about whether it matters which postcode you live in as to how long you live from your brain tumour, which may actually be true, and what are the mechanisms of tumour-associated epilepsy. And this one, which is a bit of a favourite, which is just a little data dig from our prospectively maintained database, on our patients with high-grade brain tumours. So does it actually matter if you're in a clinical trial? Does it help? Do you live longer? Is it worthwhile? So we had a look at clinical trial participation of 540 of our patients with glioblastoma multiforme. 12% were on a clinical trial, which is terrible, but actually probably one of the best figures for Australia, but is terrible that only that many patients were in some sort of a clinical trial. And we showed that, yes, certainly on multivariate analysis, being in a clinical trial, didn't matter if you got the treatment or if you got the placebo, just being on the clinical trial made you live longer. Now, you might say, well, that's because patients in clinical trials are young and healthy and educated and this and that and everything else. And so, of course, they're going to live longer because, you know, if you're 87-year-old smoker who doesn't speak English with a hemiparesis, no one's going to put you into the clinical trial. But actually, when we corrected that for age and performance status and all of the things that we know might make a difference, we still found that clinical trial participation made a difference. Now, this was great because it was the first time in the world that anyone had shown that for glioblastoma multiforme, being in a clinical trial is good medicine for that patient. Doesn't matter whether they get placebo or not. And so that's encouraged us. Lots of people have shown it for other cancers or for other diseases, but it was the first time that it was shown for brain tumours. And that's an important push for our patients to have, and for us to enrol anyone who is eligible in any trial that we have available. So that's a question. That's another question. We have the patients, we have the tissue, we ask good questions, and there's some research that only we can do. So this is one of my patients being set up for an operation. What do you notice about the patient? He's scratching his nose, isn't he? He's awake. So he's about to undergo an awake resection of his brain tumour to try and preserve speech. And there's research like that, mapping out the brain, functional areas of the brain. Are there any genetic correlates to where tumours occur in the brain and how they affect the patient? You really need a surgeon to do that stuff because they're the only ones who can actually get in there and do it. So there is some research that we can only do. And this is not one of my examples, but this is someone who I think has a neurosurgeon who's done really fantastic bench to bedside research with fluorescence-assisted resection of tumours. And this is by a guy called Walter Stummer. He was a neurosurgery resident, and he decided, how could I make these brain tumours glow so that I could see them better in the operation? And he went from dish to mouse to phase 1 to phase 3. That's him at the back there showing me how to do this technique for the first time in Victoria, which is great. You get collaborators, and if you're involved in research, you get to do fun stuff that way as well. But he went to a phase 3 that showed that if you made the brain tumour glow, then you had a much higher percentage of getting all of the visible tumour out, and that actually changed your 6-month progression-free survival. Now, the naysayers in all of this say it didn't change overall survival, but actually it wasn't powered to do that. So that the primary endpoint was that you could get more tumour out. And so this guy has gone from dish to standard of care for resection of brain tumour in most of Europe, the UK and increasingly Australia in the course of his neurosurgery residency, which I think is a fantastic story. All right. So we come to my third question, which is why would surgeons do research? Well, you really shouldn't do it if you want to just seem smart. Because let me tell you, as I sort of mentioned in the beginning of my talk, there's nothing that makes you feel stupider at times. I love that you touched on this, Ingrid. So, you know, this is the pathway diagram for EGFR. And I try and learn it every time I give a talk so I can say something sensible about it. But it's about as understandable to me as the Tokyo subway map. So that's probably not my strength. So why would surgeons do research? This is another really, really bad reason to do research, you know, just so that you seem more important. So why would surgeons actually do research? Well, it comes to the same message as anyone else has given this morning. We already do clinical care. We do clinical care, we hope, very well, but you can't do good clinical care without sort of the Venn diagram, without teaching people about how to do good clinical care and about doing research to make your clinical care better. And I really believe that you cannot do one without at least having an involvement in the other two. For surgeons, usually as a collaborator, as a question asker, as a person who provides very specific expertise, but I don't think you can do one without the other. I also don't think that you can really enjoy your career, really be fulfilled and feel that you're making a difference unless you do, and we're not talking about education here, but unless you're passing something on to the next generation and you're changing practice, even in your own little small way, for the people who you're caring for and for future generations. So I've just got the title slide coming up of another talk I've given, and I think the whole point with surgery is just that if you're not doing research, then you're not making what you're going to do every day matter. It matters for that patient, but you're not actually making it matter for the rest of the world, the rest of your profession, future patients. And you've got all the raw materials there. You've got patients, you've got data, you've got a brain, you see what's happening to the patient. I really loved Ingrid's little step that you start with the patient and then you end up with something completely different if you just ask the questions. And surgeons can do that as well as anyone else can, even if they're a little bit more time poor, they can fit that in. Just one last example of the kind of research that we've done, and obviously you don't need to read this, but this is a halfway only at poster stage because the project's in its third year of 5 years, question that we asked that I think is really going to make a big difference to our patients. So my question was, what actually is the quality of life of our brain tumour patients, over the course of like 5 or 6 years? I've got some ideas because I look at these patients, but what if we actually measured it and sort of worked out some basic questions like, if you tell me your quality of life is awful 6 months after an operation, is it still going to be awful 5 years after an operation? Or if you tell me it's great 6 months after an operation, are you going to stay up there, or is there a crossover? Because the only research anyone had ever done was look at quality of life during the placebo or the treatment arm of a clinical trial, or had got a big lump of patients at a snapshot and said, okay, this is what it was like at 5 years and this is what it was like at 6 months, but never actually look at that patient in 5 years' time. And so we're looking at our long-living brain tumour patients, and every time they come to the clinic, they have a quality of life survey that's both specific for cancer and another one that's specific for brain cancer. And they just do it in the waiting room. An army of medical students goes out and does the data, and we collate it, and we're modifying that research as we go on, and we start to get some data in. And one thing that we've found that is really interesting is that, firstly, the first year we compared our brain tumour patients to our patients who had spinal operations. Spinal patients were much worse than our brain tumour patients in terms of their quality of life, which was completely counterintuitive. Secondly, there's some really interesting stuff about survivorship bias. So our patients who had completely benign tumours and who were cured of their disease surgically but were left with some deficits like hearing loss or poor balance or some other thing like that, they rated their quality of life as being quite low compared to patients who had a tumour that was slowly, but not now, going to end their life. And they actually rated their quality of life highest, which is something about them wanting to always say that things are good, because if you say that things are bad, then something bad might be happening. And we're just starting to unpick that. So that's sort of research right in the middle of it happening, and we'll continue to collect that data over another 2 or 3 years to see what happens to these patients. And that's a really simple question. It's not hard to do. You do need a statistician to do all those numbery things because there's a lot of numbers. And that's pretty much all I've got to say, but I'd be very happy to take some questions.
I'm sure there'll be some surgeons, budding surgeons out there at least, who would like to ask some questions of Kate.
Maybe not.
I'll ask one. The standard one is work-life balance.
All right, well, Ingrid's got her own version of this. She says she's the anti-role model. I am the antichrist of work-life balance. But the reality is I could stop doing any of the components of my career that are sort of, if they got boring or I didn't want to do them. No one is, holding a gun to my head to make me do this stuff. I do it because I love it. So yeah, I'm busy, and occasionally some days I think, oh, this is just ridiculous. What are you doing? Just go into private practice and stop doing all this other stuff. But I would be so bored. So there's some juggling, but it's absolutely 100% worth it.
Yeah, I think that's an important message. Once you get into clinical practice, it becomes kind of routine.
Yeah.
Tomorrow begins to look rather like yesterday. That's why quite a lot of physicians end up running wineries. So I think that you want to keep the interest in your career going. Research is a very good way to do it. Other questions? There's one at the back there.
Thanks, Prof. Drummond. I'm interested, do you think every surgeon needs to be a researcher? What we're starting to see is all the early career wannabe surgeons are getting involved with a huge amount of research, trying to get into the training program. Do you think the focus of research has kind of been overblown to some extent?
I think we think about research in the wrong way. So I think it's great for surgeons to do, a basic science or, some sort of heavy science PhD somewhere early in their career to allow them to learn the research method. But then people think, well, but you've got to continue with that if you're going to be a researcher. And I think that's almost impossible. Very few people can go through the rigours of operating on patients. You're tired at the end of standing up for 12 hours. Things go wrong in the middle of the night. It's very difficult to do. But that doesn't mean that you don't do research. That doesn't mean that you're not providing tissue to the lab, that you're not attending a lab meeting to help give oversight to the project, that you're not collaborating with a group of surgeons who look after a disease the same as you do. I think we have to think about it a little bit differently. I think the sort of dual basic science surgeon person is very rare. Not impossible, but very, very rare. And I think to think that anything less than that is somehow not a surgeon scientist is a bad way to think.
Further questions?
Hi, Kate. My question's about, I think you mentioned you did the MD as your doctoral thesis. My question's about what you think nowadays of the difference between the MD or Doctor of Medical Science thesis versus a PhD, because understandably one has been more interesting to medical graduates to do in terms of doctoral research, but increasingly universities aren't offering it as much.
Yeah. I didn't think much about it at the time. That's what I was kind of told I was going to do by my supervisor. I probably could have submitted my thesis as a PhD in the end. It hasn't made a lot of difference to me in the path that I've chosen. I would probably advise people to sort of guts out a 3-year PhD, but make sure that it's 3 years, not 11. But I don't think it really matters. I mean, you just need some grounding in research methodology, and there's plenty of people who don't have a higher degree even who can still be involved in research. I mean, a surgical fellowship is not, a worthless piece of paper. I'm sorry if someone thinks that. That actually teaches you some stuff about doing research as well. So I think it's very individual.
Any further questions? Got time for one more.
Thank you so much for your presentation, Professor Drummond, and I like your honesty and candour with your career. I guess a question for both of the other speakers today as well, but I just wanted to hear, from our perspective, it's so nice to see how your careers ended up so beautifully, but what are some things that you've had to learn the hard way and some mistakes you've made along your career?
Oh goodness, that's a whole nother talk. Come to one of my medical students' talk where I have, I think, 10 slides on mistakes I've made. lots of things. I mean, the whole MD, I was not very good at it. I found it soul destroying. I was quite depressed during it. So, you know, and Ingrid talked about how there's definitely some stage in your degree where you think, what am I doing? This is insane. It's not going to work. I'm not curing cancer. I should just give up. I'm hopeless. I mean, there are so many sort of false starts. There's exams I've failed. There's all sorts of things that have gone wrong, but you just have to keep tacking away. Everyone has their hurdles.
Yeah, I think that we all overcome them.
Yeah.
And that's why we keep going. And I agree with your comment about MD versus PhD. I did an MD degree, by the way, not a PhD. And the practical reason why I did that was because I could write it up after I'd done the work without having to find a supervisor who was nominally responsible for me. So it was just a matter of convenience at the time. Well, look, thank you very much for that presentation. Okay. And the next speaker in the session is going to speak from the point of view of the general practitioner, and we're going to hear from Professor Moyejiwa, who's going to give us some enlightenment in that area and how research can be part of general practice, something which at the moment I have to point out is of great interest to government.
Let me tell you why you're here. You're here because you know something. What you know you can't explain, but you feel it. You felt it your entire life, that there's something wrong with the world. You don't know what it is, but it's there, like a splinter in your mind, driving you mad. It is this feeling that has brought you to me. Do you know what I'm talking about? The Matrix. Do you want to know what it is? The Matrix is everywhere. It is all around us. Even now, in this very room. You can see it when you look out your window or when you turn on your television. You can feel it when you go to work, when you go to church, when you pay your taxes. It is the world that has been pulled over your eyes to blind you from the truth. What truth? That you are a slave, Neo. Like everyone else, you were born into bondage, born into a prison that you cannot smell or taste or touch. A prison for your mind. Unfortunately, no one can be told what the Matrix is. You have to see it for yourself. This is your last chance. After this, there is no turning back. You take the blue pill. The story ends. You wake up in your bed and believe whatever you want to believe. You take the red pill. You stay in Wonderland. And I show you how deep the rabbit hole goes. Remember, all I'm offering is the truth, nothing more.
All I'm offering is the truth. If you're not going to have a Scottish accent, you have to have something, and you have to have one of those. So I'm going to talk to you about what it's like to be in primary care. And we're going to start with mathematical formulae. So this is Bayes' theorem. And Bayes' theorem says that when I see somebody with a cough in my waiting room, they're more likely to have a chest infection than lung cancer. I spent my career with ingrowing toenails. with asthma and acne and anxiety and urticaria. And yet, we spend 9% of our GDP on healthcare, and the Americans spend 16% of their GDP on healthcare. And yet, our results are better. And if you read the work of people like Barbara Starfield, you will know that this is primarily because of primary care. And that's part of the story that I'm going to tell you, and the reason why research in primary care is so important. 125 to 145 million consultations with GPs in this country every year. But here's a problem. 80% of people will develop symptoms in the course of a month, and 10% will attend a GP, 3% will have some other kind of contact with the healthcare services. But 50% of people under the age of 50 will go to a different doctor or a different practice on each and every occasion. So we in general practice have to find the pathology. But in fact, in many ways, in most cases, we know very, very little about our patients. We don't know what job they do. We don't know who their partners are. You could have a lineup of people to say, the last patient you saw, which one is their partner? We would have no clue. We don't know what neighborhood they live in. We don't know their family history. We don't know if they have debts. Yesterday, I was in clinical practice. It's amazing the number of my patients who are forklift drivers who had gastroenteritis yesterday. And they're feeling perfectly well today. All I had to do was write a certificate. So what's going on here? This is one of my patients. This is one of my PhD students who made the video.
Hello, Rebecca. We haven't met before.
Yeah, I normally see the other lady doctor, Dr. Susan, but I can't wait until Friday. This pain is really bad. I'm suffering. You might have heard from her. I've got this horrible pain that moves from this side to this side, and I work at the bakery and my work just makes it worse. I even ended up by going to the hospital 2 days ago, and they gave me this tablet. I think I need more tablets. This pain is just too much for me to handle. I can't go to work.
Okay, Rebecca, the tablets you were given were oxynorm and an antibiotic, but I see your urine test came back normal. Why don't I examine you and then we will see what I can do for you?
Yeah, I can't go to work.
Clinical examination was entirely normal. This was her 8th consultation in 2 months. If you really want to know, I'll tell you what the story was later. So the other challenge we have is that 47% of our patients have multimorbidities. And classically, hypertension, hyperlipidemia, osteoarthritis, that's 1 in 20 of our patients. Most GPs will deal with at least 3 problems in a consultation, ranging from 1 to 10. And we do that in 10 minutes without an MRI, without a CT scan, or without any other investigations. So let's talk about investigations. There are lots of studies published that show that around 68% of tests that you guys are going to order the day you qualify are entirely unnecessary. They do not change the management of the patient's condition. That's 2 tests per day of hospitalization per patient, and on average, an Australian patient will spend 6 days in hospital. And this is the consequence. This is from Stephen Duckett from the Grattan Institute, who wrote a lovely piece in The Conversation. And what he says is this, that population growth, certainly there are more Australians, accounts for some increase in the cost of healthcare. Population aging, yeah, we're getting older. Health inflation, that adds a little bit. But the most increase in the cost of healthcare to our country is by new, and in inverted commas, improved and more services per person. So I go back to my consulting room. and I see a patient who says to me, I'm here for the results of my CT scan. So I say to her, well, what was it ordered for? And she said, oh, it was tummy pain. It was ordered for tummy pain last week. So I look in the notes, and the notes say, abdominal pain, CT scan. So I said, well, the doctor doesn't tell me quite what's wrong with you. He didn't give you much of a history. He didn't seem to have examined you. What happened? And she said, there was no history taken. There was no examination. I'm here for the results of my CT scan. And this is a common story. It's happening a lot. And it's happening particularly with younger doctors. It's an extremely worrying trend in how we are now practicing medicine. And it costs not just money, but it costs us in terms of hospitalizations of patients whom we cause harm. 45,000 hospital episodes for the complications of medical and surgical care, and that was more than a decade ago. Numbers are no different now. But there is another trend that we need to be thinking about. 80% of our population will be either overweight or obese by 2030. 80%. And the consequence of that is that we are going to have much more, if we don't already, chronic disease. In fact, 74.2% of the stroke burden is attributable to smoking, poor diet, and low physical activity. And here is where primary care can make the greatest impact, and particularly primary care research, which is what I want to talk about. So what we need to do is think about changing people's behavior. So how does that work? So I say to you, well, you need to change your behavior, you need to, to eat a little less rubbish, do a little bit more exercise. You think about the pros and cons, and you think, yeah, that sounds doable. It's not going to cost me that much. I can get gym membership, blah, blah, blah. And then you're driving home, and the golden arches appear, and you're starving. And you think, it can't hurt to have a small chips and a small strawberry milkshake. And your brain is going, yes, dopamine. And this is the core of addiction. We have to be thinking about the environment in which our population lives. But there is hope. This is a major teachable moment. At this age, people think, I'm wearing glasses, and I can't hear you very well. And that's at size 36 I'm in now. And they see their parents who are in their 70s who have those chronic illnesses. And this is a moment at which we can intervene to change people's behavior. The teachable moment. And I want to talk to you a little bit about the teachable moment. So this is a teachable moment a la McBride. What it says is when there's a teachable moment, you get a great emotional connection. You really have an impact emotionally. So I'm going to give you an example of what I mean. When my son, my middle son was 1, I was left in charge of giving him a bath. And I was distracted. And I ran the bath. And Kieran wandered into the bathroom and stuck his hand into the hot water as it was being run into the bath. And the poor kid screamed. I screamed. And at that moment, that was a very teachable moment for me in terms of, child safety. I had this screaming child with me nearly in tears, emotionally connected, realizing that this is a risky situation. It can happen even to my kid. And I saw myself as a failed father in that moment. And that led to the acquisition of skills, motivation was high, self-efficacy was high, and by jingo, it never happened again. This is a teachable moment. This is a teachable moment, and there are many others like it if we care to think about things, think about our patients in these terms. What we need to do is trigger people to do what they already want to do, and that's the secret. We have 10 minutes in primary care to make a change for our patients. and that's what I want to talk about next. But before I do, it's not just an event. There are also, physiology plays a part in this as well. So here is a circadian rhythm, and you can see that our level of alertness and wakefulness changes across the course of the day. There is a moment mid-afternoon when pain thresholds are very high. So it varies. So when you're doing research in pain, you have to bear in mind when the patient was asked what their pain levels are like. But it's not just that. This is a menstrual cycle, and there's research just been published that shows that a good time to try to stop smoking is in the follicular phase of the cycle. So I went off to Stanford University and spent time with B.J. Fogg, Professor Fogg from there, and he has this wonderful way of explaining all about triggers. You want to trigger behaviors, and this is how he explains it. He says, triggering people can only happen when motivation and ability are aligned. So here's the examples that he points out. So there on the left-hand side is somebody who's highly motivated but isn't able to do what they want to do. They're frustrated by their computer. No matter how many times it says to them, delete, they can't delete because the machine is frozen, right? They're frustrated. At the bottom is a guy who says, ninjas killed my family, need money for kung fu lessons. No matter how many times you rattle the cancer council box under his nose, he's not going to make a donation. On the far side is where healthcare tends to be. Things that are relatively easy to do, but motivation is not very high. It is extremely difficult to motivate people to change their behaviors. If it wasn't, we would not be winning gold medals in the pool and gold medals for melanoma in Australia. Where you want to be is in the top right-hand side, because when the baby cries, the parents go to it instantly. They are triggered, the behavior is triggered, and there are many such recipes for triggering. And I want to talk about one that we've used. So a number of years ago, one of my PhD students did a study where she looked at offering people photographs of themselves as they would appear as a smoker and a non-smoker at the age of 55. And just by offering that one image, 1 in 7 smokers stopped and were confirmed as having stopped after 1 year. It was a trigger, the trigger being this is something they were motivated to do, and they decided enough is enough. This is what I'm going to do next. All right, let's go back to the consulting room towards the end of this presentation and talk about the challenge. And this is the challenge. Here is the enemy. This is the busy clinician. They do not want to do research. The last thing they want to talk about is research. And this was a situation that we were in 1998 in the UK, where I was working as a GP. We could not keep doctors. We could not keep doctors because they were working long hours, and particularly female doctors, because that meant they couldn't return to the family. A lot of them wanted to go back and be there for bath time or whatever. We had a conversation with them and we said, look, we really need you to stay. We're desperate, blah, blah. Nothing would change their minds. So I then found myself as a senior partner in practice talking to my reception staff. And I heard them talking on the phone, and I heard this lady saying to the patient, Janine, sounds like he's got a cold. I'll fit him in on Thursday. This is on a Monday morning. Just give him some Calpol. And I went up to her and I said, can I see your medical qualifications? And she said, what are you talking about? I can't run this surgery for you and not put patients off when they need appointments. And I have no appointments to offer. So I said, what would make your life easier? And she said, stop me having to tell my neighbor, my friend, that I can't fit her kids into your surgery until Thursday. Thank you. I'm busy. Goodbye. So I went next door to one of the GPs and he was about to leave. And I said, Ian, what would make your life easier? And he said, if I could get out of here before you come into my office. That would make me really happy. And I said to him, well, you know, he says, I'm going for an interview. I'm going to get a job, right? I'm going to Coles. I'm going to work in the butcher's counter. Because this is too hard. He wasn't serious. Anyway, I don't think so anyway. So I said to him, okay, well, let's talk later. And I went home to my wife. This is not my wife. This is somebody from Flickr Creative Commons, where all the pictures are from. And I said to her, what would make you happy? And she sort of looked at me and she said, what have you been eating on the way home? I said, what would make you happy? So she said, look, we've got a sick kid. And I phoned the surgery this afternoon. This is another surgery because I don't treat my own kids. And she said, they tell me I can't speak to the doctor. I've been speaking to the nurse. They give me all this advice. I just need to talk to the doctor. If I could speak to John, our GP, I could actually, you know, maybe cope until I see him on Friday. So I went back to the surgery and we looked at the records for same-day appointments. And there was a seasonal pattern, a classic seasonal pattern. And at the time, I happened to be working at Sheffield University, working with someone called Mike Campbell, who many of my senior colleagues will know. He's a very eminent biostatistician. And he looked at the pictures and he said, this is a classic time series. Every year you've got a classic pattern. And if you put an intervention, you're going to have to show a change throughout the year, an improvement throughout the year if it's to be a successful intervention. And so we did. We banned the receptionists from making appointments. We asked the doctors to speak to patients who were looking for a same-day appointment, an appointment for which there wasn't room in the schedule. And we followed them up for a year. And what we discovered was by doing that, we dropped the demand for face-to-face appointments by 40%. I happened to be working next door to John Oldham, Sir John Oldham, who was in charge of NHS policy. We showed him this, just the data. This is what happened when we introduced this policy. No grants, no huge publications. We published this in the BJGP. It became national policy. And as a consequence, when you go to the UK now, advanced access, your GP will phone you when you need an appointment. So the major challenges going forward are to find teachable moments. We've talked about pregnancy, we've talked about the 50th birthday. There are many others, and many of my students are involved in dealing with those, testing triggers in those teachable moments. We need to do something about iatrogenesis. We cannot continue ordering tests and ordering drugs that are actually harming Australians. And we need to find triggers. You saw one, photoaging for smoking cessation. There are many other triggers that are efficient that can be used within the 10-minute GP consult in order to make a difference to outcome for patients. And for those of you who are interested in the patient experience as designing interventions in whatever area you're working in, the new Journal of Health Design will be launched next week. The website address is there, and you may want to read my blog in which I talk about my many patients on, well, de-identified, of course, leanmedicine.co. Thank you.
Thank you, Moyes, for some very interesting insights into the world of general practice and how to be consider research within that career. Have we got some questions? Well, we have some with two here and one here. People with things, there are two, and one up the front here as well, please. So yeah, you've got two there, and then one up here. Do you want to bring up the other one there? That's great.
Thank you for your presentation. It was very insightful. I've got two questions. First of all, I'd just like to know what was the reason for your patient's multiple presentations, and also wanted to get your ideas on why you think we're ordering more tests, whether it's lack of time to take a good history and examination, or whether it's patient-driven and they're asking for more tests, or whether we're less capable of dealing with the uncertainty?
I think that I'll answer the second question first. We are increasingly moving into that world of ordering tests because it's seen as a way of getting patients in and out the door. We are, particularly in some parts of this country where we've got large corporate bulk billing practices, there are some very nefarious practices, and I'm going to say that, I think it needs to be said, where you get 3-minute, 5-minute appointments, patients going in with a complex problem, and they think, well, medical legally I'll be fine, I'll have a CT scan for somebody who may turn out to have appendicitis. So that may be part of it. The other part of it is I think we need to make sure that our undergraduates understand that the positive predictive value of tests. I don't think this is taught often enough. That often you do a test, and if it's negative, it doesn't mean it rules out the condition, and if it's positive, it doesn't mean it rules it in. There's a science behind that. But you asked me a very good question. So that lady that you saw had multiple presentations with abdominal pain, with rashes, with headaches, and she had gone through a whole raft. She'd been a whole raft of tests, been to hospital many, many times. So I said to her, I have no clue what's wrong with you. Hand on heart, I have no idea. And I am not going to order any more tests because I don't know why I would be ordering those tests. But I tell you what, I've got a pill here that just might help. So I prescribed Fluoxetine. And I said to her, this will help you with the symptoms. It'll help you feel a little bit better, and then maybe the symptoms will get better. So she took it, and off she went. And 2 weeks later, she came back, and she said to me, I feel so good. I have been cured. This is fantastic. And I said to her, so the Fluoxetine did the job. She says, I never took your tablets. My father, she said, became the governor of Southern Sudan a week ago, and immediately put my mother-in-law and father-in-law in jail. So I said, well, why does that make you so happy? Now he will divorce me, because in my culture, I cannot walk out on a man who I find loathsome. Now he will divorce me, and I can go back into my community with my head held high. And I realized then that we know nothing about our patients. And she'd been driven into this medical model where we'd been busy basically CT scanning her 8 times a year because of an unhappy marriage.
That was a beautiful and important story. Thank you, Professor. I really love the idea of teachable moments. Can you provide some more example of triggers that you've used with your patients? I suppose we can't always wait for pregnancy or the 50th birthday to come around. So what are some triggers that you've used with your patients?
Yeah, look, we can actually target those patients. They come along, they often come along for very different reasons. They come along because they want their blood pressure checked or whatever. And really it's up to us, it's incumbent on us to recognize that as a teachable moment and say, okay, let's talk about this. You need to invest in your 50s to recoup in your 60s and 70s. And, let's talk about what it is that you can do. Some of the other triggers we've used a lot of apps. One of the apps is called the Hunger app. And essentially it says to you 4 things. Never eat standing up. Never go shopping when you're hungry. Never eat in front of the television. And there's one other one which I've forgotten. But essentially there's these 4 simple bits of advice. It's not a funny diet. And it says every time you are hungry or you're tempted to eat, you take a photo. And it basically says where you were, what you were doing at the time, what your mood was like. And then you bring them back in a couple of weeks and you talk about it. You talk about what it is that's driving people to consume more food. And often it is, I go this route to work and there are the golden arches. And you say, just change your route to work. That's one of the triggers. And so we've got a number of students who are actually using these in other teachable moments like hospitalization, like being given test results, and there are a few others.
There's a question up here.
Sorry, it's a bit loud. Thanks, Professor. I had a question about your teaching moments point. So in like a lot of behavioral psychology, there's a teaching moment, but you also need to sort of motivate, the patient or whatever to change their behavior. And so you talked about teaching moments and how they're important. But I'm just wondering, outside the clinic, say for example, you're talking about this obesity trend and people eating junk food. The reward for that, which is that they sort of get into better physical shape and they don't get these diseases or whatever. That's a very long-term goal, and it can be really hard for a patient to see the benefit of missing out on one cheeseburger or whatever. So in terms of motivating patients to uphold what you teach in the clinic, what are some of the strategies that you use to do that?
Yeah, look, so really, you're right. Some of these are long-term goals, and often you will get recidivist behavior. So somebody will come along, they will try something for a little while, it won't work, and they'll try it again, particularly the smoking cessation one, the April age, face photo aging. But one success is enough. If they do it for long enough, you can go back to that patient and say, you did it before, would try again. These are very, very complex reasons that people have these behaviors. It's not just because they're overeating. It's often the roots are much deeper than that. It's the unhappy marriage, it's the debt, it's the bully boy boss. It could be any number of things. And we have to be patient enough and walk with the patient the point where there's another good opportunity to intervene with another or similar innovation.
Thank you.
Well, thank you very much. Please join with me in thanking Moyes for a very interesting insight. So we're going to change tack completely now and go to the dark side, as it were. Not really. I'm really honoured to introduce Professor Andrew Cuthbertson, who's Chief Scientific Officer and Director of R&D at CSL since 2000. He's responsible for CSL's global research and development operations, a huge task, and has a major interest in the biopharmaceutical industry, and you heard a little bit about that before from Ian, and oversees a budget of $430 million. Andrew trained in medicine and science at the University of Melbourne and then did, I think, his PhD at the WEHI, the Walter and Eliza Hall Institute, also worked at the Florey, and finally ended at the NIH in the US, and then worked in industry at Genentech in the US. This year, Andrew was very appropriately made an Officer of the Order of Australia and an Enterprise Professor by the University of Melbourne. Now, sometimes those of us in ivory towers or institutes such as universities or institutes look down on industry, and I'd put it that this is a dated view and that we need to engage more with far more diverse concepts, expertise, and help us to think laterally for new solutions to old problems. So we gave Andrew the unenviable task of talking about clinical research in industry and crossing to the dark side. Andrew.
Thanks a lot, Ingrid. And look, I did try to dress appropriately, as befits my title. And I would just say to Ingrid and Ed, I never had a forum like this when I was a medical student, and I think it's fabulous and definite progress. And I know everyone here is thinking about their careers during today, and someone mentioned earlier, I think it was Ian Fraser, talked about the wine industry as a potential diversion that some medically trained people make. And in my family, about half my family actually work in the wine industry, and I can assure you that the old saw, or the old question, how to make a small fortune in the wine industry, the answer is start with a big fortune, is absolutely true, and I would encourage you to stick to the path that you've chosen. So I was asked to talk about physician scientists and industry, and I want to define a few things for you that might not be clear. Then I'll say a few words about my personal path, for what it's worth, and try to pull it together and say a little bit about CSL and the importance of physician scientists. We employ 30 or 40 physician scientists at CSL doing really important development work. And I won't use any slides, and it may be, and you can tell me at lunchtime, it may be that's the most memorable part of my talk. I hope not, but I do want to try to engage you and just speak to you. So what do we do in industry? What's the role of industry in our Western society? And really, we collaborate very closely with our academic colleagues to translate medical science discoveries into new medicines and deliver them to patients around the world. That's the role of industry. And it's not that the discoveries made by our academic colleagues and they throw it over the fence and then we develop it into a new medicine. It's all about translation, which you hear about a lot, and it's a big topic with our Prime Minister and their focus on their innovation agenda, but this whole notion of translating some of the basic science discoveries that we're very good at making in Australia into patient benefit. The part I'm going to talk to you about today is about the biotech industry, in other words, translating discoveries into a new recombinant protein in a vial to save lives. That's what I do for a living, and it's an interesting topic, but translation is much more than that. Translation could be translation into treating patients with chronic lower back pain with alternatives to surgery. For example, it could be about implementing, as Ian alluded to, better infection control measures to reduce and try to control the huge threat of antibiotic resistance. So they're all examples of translation, and I like them all. It's just the bit I'm going to talk about relates to biotech drug development. But this whole notion of translation is central. It's not an over-the-fence thing. Translation to me means an engagement and collaboration between academia and industry that can go on for years. I mean, for example, we worked with Ian Fraser at CSL, which was wonderful to be involved in the development of Gardasil, but the development of that HPV vaccine took 17 years from the initial discovery to when it was first launched. And the collaboration between CSL and Ian's lab was about 7 or 8 years. So translation is a wonderful creative process, but it's not for the faint-hearted. It takes a lot of time and good behaviour, mutual aims and so on, but that is really at the heart of connecting academic research with what industry is supposed to do. Industry is characterised by big teams, you know, and if you think research is expensive, and good research is expensive, and we're all trying to increase, you know, the funding of basic medical research in Australia, the D part, the development part, where we take a new medicine candidate and characterise it, scale it up, take it into first in human clinical trials, and then into patients with disease, and then massive safety and efficacy studies. If research is expensive, the D part, the development part, is hugely expensive. And it requires, in our system, companies with the commitment and the funding who are prepared to take the risk to take these things through, hopefully, to fruition. And, you know, just to give you some idea, if, for example, we say there are 100 fabulous world-class basic science discoveries in medicine from our universities and institutes every year, probably in those discoveries, which should and will be published, there might be 5 or something, I'm sort of making it up, but say 5 that are the basis of a new biotech candidate molecule. And of those, there might be 1 or 2 that get through preclinical testing, animal model testing, and into the clinic. And there will be a fraction of 1% that end up you know, in a vial distributed to patients around the world, and so on. So very high risk, not for the faint-hearted, very expensive, but very rewarding ultimately for patients and economically. And I guess another passion that I have and others in this room is that the value adding from taking a candidate molecule to a molecule that shows activity in a phase 2b study in patients is probably 100-fold. It's many logs of value addition. And something I'm passionate about is we should be doing more of that value-adding work here in Australia and retaining the economic benefit in Australia rather than those wonderful discoveries going offshore too early. So the value-adding for patient care and economically to Australia can be huge if we get it right. So this is what I really enjoy doing, and it was a bit of trial and error, and I'll shoot through, you know, how I got to realising that what I really love is seeing first-in-human data. That is the best thing. Well, particularly if it's positive, actually. Let me clarify that. But when there has been years of wonderful basic science work, preclinical testing, animal model work and so on, often safety testing in healthy volunteers, but then to go in very carefully to a group of patients with appropriately thought through endpoints and find that this new biotech product actually does what we thought it would do is, for me, the best thing professionally. So how did I come to realise that? Well, it wasn't when I was a medical student. I did medicine, as Ingrid said, at the University of Melbourne, diverted for a year, did a year of medical history, which was a little unusual, still unusual, but it was really good fun. Finished my medical course, then worked for a couple of years at the Royal Melbourne Hospital. And at that time, really based on some wonderful mentors I had, I really wanted to be an eye surgeon, an ophthalmic surgeon, because I thought the combination of the technological breakthroughs that were occurring, you know, we're talking a few years ago, but the breakthroughs in terms of microsurgery, instrumentation, and the importance of vision to patients, the ability to actually change patients' lives with your own hands was just a fabulously attractive thing to me. And but my interest in ophthalmology was also responsible for quite a huge career change, because I was body surfing at Lorne down the coast with Doug Costa, who was a wonderful chair of ophthalmology at Flinders University, and we both managed to catch a wave. And as Doug stood up, he said, "Why don't you do a PhD?" And I'm clearly easily led, because I said, yeah, good idea, you know. And so instead of finishing my surgical training, which I was about to start in eye surgery, I went to the Hall Institute, did a 4-year PhD. I was a bit slow writing up, having a good time. And it completely changed my life. I never went back to what I still think is a wonderful part of the profession, but I never went back to clinical ophthalmology. I then did a postdoc at the Howard Florey Institute. So those of you who are counting, that was 3 years. So I've been training for 16 years at this point, you know. I didn't pay for my education. I'm old enough that it was considered part of the responsibility of the country to fund higher education, which is something I'm eternally grateful for. But I had been training for a long time, and I then, I want to emphasise the importance to you of making serendipitous phone calls. I had, and feeling confident. I had at that time, because I was interested broadly in vision research, identified a really interesting person called Joram Piatigorsky, who studied the evolution of proteins, and he chose to study the crystalline proteins, crystalline gene expression in the lens of the eye. So you might say a bit of a stretch, but it's a fabulous system for understanding convergent evolution in proteins. And he published his work. I read his work. I found it fascinating. I realised he worked at the National Eye Institute in Bethesda, Maryland, in the US. So I called him up and I said, and he came on the phone and I said, hello, Dr. Pietrogorski, I'm Andrew Cuthbertson and I'm in Australia and I've stayed up late to call you. I hope I've got the time right. And he said, yes, okay, fine. And I said, I've read your work and I really find it fascinating and I'd like to come and work in your lab. And it could have gone a number of ways, but he said, sure, fine, when are you coming? You know, and I would just say, and I do think it's one of the fabulous things about the United States and other countries, but I benefited hugely from the generosity of the United States in terms of, sure, you know, come and work, it's really crowded and, you know, stuff, but if that's what you want to do. And so I went to the US. I would just say, and had some wonderful experiences, and I won't, you know, go into them maybe over lunch, but I was attracted to this fellow Pietrogorski purely because of what he'd written in the scholarly literature. He's a leader, absolute leader in this very narrow esoteric field. But when I got there, I was lucky enough with my girlfriend at the time, now my wife, Christabel, we were invited to the Pietrogorskis to celebrate the Super Bowl. So, okay, sporting event. So didn't know anything about it, went along, and all I knew about Joram Pietrogorski, my lab head, was that he was an expert in the evolution of proteins in this particular weird model. And we had to rent a truck to move some furniture. We didn't have a car. Drove out in a snowstorm, you know, to the house, you know, pre-GPS, had a map, got out there to an area of Washington, DC called Potomac. And Potomac is a very wealthy neighbourhood, like a seriously wealthy neighbourhood. And, you know, people have deer, you know, roaming in their front yards and things. And we were driving along and I said, are you sure we've got the address right? Because, you know, anyway, we found the address, Persimmon Tree Drive, pulled the big truck in, and there was Joram. You know, you could sort of see the house because it was so huge. It was still a kilometre away. And drove up the drive in this big U-Haul truck, and there was Joram, because we were about an hour and a half late, and there was a snowstorm, and he was worried that, you know, we'd been lost. And there was a big circular drive, and with this beautiful lawn in the middle of it, you know, about the size of this room. And for some reason I panicked, and he was sort of waving, you know, saying, stop, stop, you know, and I pulled the truck onto the lawn for some reason, you know. And being in a snowstorm and wet and mushy, I then hit the brakes and it tore these two huge trenches in his lawn, you know, in metric measurements, maybe 10 or 15 metres, you know, something like that. And then I thought, well, I better take it off. And he just came out and said, leave it where it is. Leave it where it is. So anyway, I'm getting distracted. But I remember it really clearly. We then went into this big house. And you have to remember, NIH the facilities are really pretty crappy. It's a fabulous place to work. But all I knew of this man was that, you know, he was my boss. His name's Pietrogorski. He runs a great lab. So this didn't really match up. You know, he's a US government employee and he's got this massive great house with a destroyed front lawn. And so we went in, Christabel and I went in, and the first thing we thought, you know, because we're pretty smug, this is a long time ago, thought we knew quite a lot about artwork and things and a bit snobby, walked in and we were nudging each other because there were paintings on the walls that I recognised, like Frans Hals, you know, particular sort of Dutch masters and, you know, and then some wonderful early 20th century pieces, and we just thought, you know, and they had lights, you know, little lights illuminating them, and we were sort of going, this is really crass, you know, come to America, they have all these prints on the walls, you know, but on closer inspection, we realised they were the originals. And we thought, whoa, you know, this, again, what's he doing as a lab head, you know, at NIH studying protein evolution? And anyway, to cut to the chase, so it turned out, and as we got to know this wonderful man who turned out to be a fabulous friend and mentor, but he wanted to be valued and regarded as a basic scientist, as a wonderful basic scientist. That's what he presented to the world. But in fact, his background was quite interesting. So his dad, Gregor Piatigorsky, was one of the greatest cellists who ever lived. He was a Ukrainian Jew. He'd escaped across Europe, made it to the US, and met his wife, who was part of the Rothschild banking family. And between them, they collected paintings. They played wonderful music, collected paintings, and were quite wealthy. But this was the family my boss came from, and so all I'm saying is sometimes making the phone call, making the connection can be fabulous from a career point of view, but also come with wonderful other dimensions as well. So look, I then enjoyed protein evolution. I felt, but you've done medicine. You should be, you know, it's fine doing really basic science, but I felt a need to try to get back to something that was clinically relevant. And I had read a fabulous issue of Nature in 1984, where there were 3 back-to-back articles published. Like, you know how hard it is to get a letter into Nature. Well, these are 3 back-to-back articles on the cloning, expression, characterization of the gene, et cetera, of human factor VIII by the team at Genentech in San Francisco. Just, you know, mind-bogglingly, both incredible science at the time and also incredibly relevant if you suffer from haemophilia A. So again, I called the people at Genentech, and I think because of my training that I'd received in Australia, I went out for an interview. I'd become interested in gene therapy actually when I was at the National Institutes of Health, and I started the gene therapy lab at Genentech in 1991, working on factor VIII gene therapy, something that still hasn't been solved, so I don't claim we cured that, we solved that one. But while I was there, and again, just an example of perhaps being in a place and having an open mind, I had the opportunity to go back to my interest in vision research because a fellow scientist there was a very interesting man called Napoleon Ferrara, who had discovered VEGF-A. He's a very interesting Sicilian, proud Sicilian, Napo, and I was able to work with him. So he was very interested in the role of VEGF-A in driving cancer metastasis, because it is the major cytokine that drives new blood vessel development. And just because of my background, I was able to make the link, and I do remember that moment of making the link and thinking, you know, if it drives new blood vessel formation in tumours, maybe it could have some involvement in age-related macular degeneration, or the wet form, which is characterised by new blood vessel formation under the macula. And at that time, again, because if you had ideas and you thought you could take them into clinical development, that was a great place to do it at Genentech. And I was able to work with the colleagues there on a project that eventually became the first biotech treatment for macular degeneration. It's called Lucentis. So that was a bit of a blast. But pulling these things together, and just to close on a few words about CSL, CSL began 100 years ago, so it's our 100th anniversary this year. It was started in 1916 as the Commonwealth Serum Laboratories to protect Australia because during the First World War, on the other side of the world from everybody else, we were feeling very isolated in a time of war for provision of basic biological medicines, diagnostics for animals and people, was really how it was set up. The first 75 years of CSL's existence was they had some very proud achievements, like being the first to provide penicillin to civilians in the 1940s, first country in the world. Animal-derived insulin, a whole lot of biological medicines. It hit the wall, as these sort of organisations did about 25 years ago, when the regulatory requirements kept rising. The advent of recombinant DNA was around the world and exciting everybody. And as part of the Commonwealth Department of Health, it was really impossible to invest appropriately in R&D and innovation to be at all competitive with anybody else. So it was really dying. The government of the day decided to privatise CSL. They floated it on the stock exchange. Quite a bold move, but it was sort of fashionable at the time. Commonwealth Bank, Telstra, others. But CSL was floated as a quite inward-looking, because that's why it was there, inward-looking Australian organisation. And since that float, which was in 1994 to today, has been a really interesting time to work there. I've been there for most of that time, but it's really been a matter of figuring out what we could do that was internationally competitive. What are we good at? Getting rid of the things we're not good at, can't be competitive, focusing on protein-based drugs for human disease, serious human disease. That's all we do. And we've got a lot bigger, so that now, interestingly, CSL is, I think, the 6th or 7th biggest company in Australia on the stock exchange. We're the only company that does advanced manufacturing in Australia, if you think about it. Have a look at the list. Probably in the top 20 that actually manufactures products that are based on years of research and development. So it's a pretty cool place to work. It's headquartered in Parkville. The world headquarters is still here in Australia, but by necessity, because you cannot develop new biotech drugs for Australia. It just does not make sense. You have to develop them for the world. A lot of our activities are now in the Northern Hemisphere, but we're headquartered here, and our head of R&D lives here. I live here. I'm here some of the time. And it's now an organisation of 16,000 staff around the world, 30 countries, 1,200 R&D scientists, including a lot of physician scientists. I say that because we now have the capability to do stuff. When I started, the budget in R&D was about 30 million a year. And in fact, this financial year, we will spend nearly $1 billion on R&D. So it's not so much about the money, but it means we can do stuff. And I'll close by saying one of the most gratifying things to me has been that this year we're launching our first 2 fully CSL-developed biotech products after 12 years' work. I don't know why we did 2 at the same time. That's been a nightmare, but we'll get there. And, that's a 12 years from inception, from collaboration with academic colleagues in Australia, Germany, Switzerland, through to development programs that have cost hundreds of millions of dollars. But we now have these products registered in the US, Europe, trying for Australia, Japan, other parts of the world. So that is gratifying. And what I would say is, I get to treat 100 or 1,000 patients at a time. And that's what you get to do if you work on the dark side. And physician scientists are absolutely critical to us. And as a mark of that, and this doesn't solve the problem, but I know Ingrid understands this very well, there is a bit of a valley of death in the career development of physician scientists, and mid-career. And so to mark the 100th anniversary of CSL, we have committed, and we've actually just launched the advertising for centenary fellowships to support mid-career physician scientists. And the critical thing about them is they will be 5 years, so not 1 year or 3 year. They're 5-year fellowships, 1.25 million a year for 5 years. Sorry, 1.25 million over 5 years. 250,000, don't get too excited. 250,000 a year for 5 years. And I'm really pleased, and I'm afraid, you know, there are only at the moment 2 a year, but we're going to keep adding to the pool. So it doesn't solve the issue, but we're hoping that these fellowships will be taken up by wonderful people to support them through that critical mid-career phase as a physician scientist. So I will leave you with a couple of messages. Industry translates scientific discoveries into new medicines for patients. That's the role industry plays in our current world system. To be successful in industry, you need a very strong basis in academic training. We're not interested in people who are failed academics or, you know, and if you look at the people, and I could introduce you to some of our physician scientists, they actually have had wonderful academic careers. They've chosen to go into industry. They may go back to academic careers after 10 years in industry, and that's the way I think it should be. To be attractive to us in industry, you need to have more than one dimension. And, you know, for example, being a physician scientist has 2 dimensions. It's fabulous. It gives you options and choices that if you only have training in one of those streams, you don't have. But, you know, we love to employ wonderful physicians who are interested in mathematics and biostatistics and model building. We're really interested in people who can write regulatory dossiers and engage and explain in 100 pages to a regulatory agency why they should license a new treatment, for example. So try to have more than one dimension. If you like the idea of treating 1,000 patients at a time, industry may be for you. And I would finish by saying that your training in Australia in science and medicine is really first class, and you should believe in that and believe in yourselves, because it really is. You know, when I say I made some phone calls and people, you know, there's a bit of luck involved, but people were interested because when I told them about my training and what I'd done and people I'd worked with in Australia, it was attractive to people in other parts of the world. So go and work in the most challenging, exciting environments that you can find. Leave Australia, go and explore the world, but then come back here for the rest of your career. Thank you.
Oh, thank you, Andrew. I think your enthusiasm was palpable. I'm sure there'll be some questions. I'm going to go a little bit into lunch so we can have a bit more discussion. There at the back, there's one there. Thanks. Is there one over this side as well for the other microphone?
Thank you for your presentation, Prof. I just want to talk a little about translating research into the clinical environment. And I think you would agree there's a lot of exciting technologies and pharmaceuticals that are in the pipeline still. And bringing those products to market in Australia, I've heard, is often tricky, to the point that some people actually take the technology, take the drugs elsewhere, to Asian markets or to European markets. They'll register it there because it's actually easier to register and get it off the ground outside of Australia than it is to actually develop a product here and bring it to market. And obviously in a time when we're supposed to be innovating, it doesn't quite add up, and we need to sort of work on our approach to developing products in Australia. Would you agree that it's difficult to start products in Australia, and then if you do, what do we need to do to solve that problem?
Look, thank you. Really good, several questions, very good questions, and just in the interest of time, let me try to summarise. We need to develop products for the world, and I'm afraid, for novel breakthrough biotech products, you really need to develop them for the US and Japan and Europe, not just Australia. Australia, of course, we think about Australia, but you need to develop them for the world is the answer. How you go about that's really interesting. And what I would say is the more of the early stage work that we can do in Australia, the more there are a whole lot of spillovers in terms of training people, patient access to really novel therapies, and economically for the country, it makes sense. What I would say is eventually doing phase 3 registrational studies requires so many patients and such a broad range of physicians involved that you have to do it internationally and outside Australia. Would be pretty unusual to be able to register a product worldwide based on phase 3 data generated just in this country. But I think to be positive about your question, discoveries made in Australia can stay here longer, and we can definitely do the early to mid-stage clinical development in Australia. And then ultimately, you would do the late stage, the phase 3 studies all around the world.
What is the rationale you use at CSL for determining whether a particular fundamental biological discovery is a viable candidate for translating into a treatment?
Yeah, look, again, really good question, and so just so we're clear, we have about 65 formal collaborations with academic groups in Australia and other parts of the world, and they are all based initially on a discussion about a discovery which is usually a biological activity associated with a molecule. Sometimes it's more than one molecule, but ideally it's the investigators know what the molecule or molecules are, and there's a biological activity associated with it measured in an assay or an animal model and so on. And it's really from that start of that discussion, and to answer your question, that there are a whole series of dimensions to understanding things like, is it real? Is it novel? Could there be a therapeutic benefit from this biological activity, through to what is the molecule? Is it a single molecule? Could we make it using recombinant DNA technology? Can we scale it? Is the protein stable? Could we formulate it? What's the side effect profile liable to be for toxicological studies in animals, cautious first entry into human studies? Part of it, but by no means the whole of it, is what is the commercial opportunity. No one will spend 800 million developing something if there is zero chance of it ever producing a commercial return. So these are all multiple dimensions of that discussion that we have with our academic partners to determine whether this is something we want to spend the next 5 years working on together or not.
Okay, well, if there are no more burning questions and you're all dying for lunch, I'd like you to help me join Andrew in thanking Andrew for taking us to a whole new world. I hope it's opened your perspective even further. Thanks very much.